Walaikum assalam. Assalamu alaikum. Welcome to our today's session. I'm Dr. Mahin Ashraf from Imaging Study. And today, as like before, we are going to share some ultrasound cases with you. I think these videos are getting very longer in recent days, so people are getting toxic. So we have tried to shorten the video, including just 5 cases and excluding the extra topics for the month of Ramadan. But after Ramadan, we will continue our big sessions like 5 ultrasound cases, then a specific topic, just like before the Ramadan we did. So, if you're new to our program, I'm from Bangladesh, and imaging study is slightly old now. So, it has got a YouTube channel named Imaging Study, as we said, with 63K plus subscribers, and we have already uploaded 478 videos on our YouTube channel. So, if you're new to our this program, we continue our program on every Friday. This will be a free session of around 1 hour long. And we try to share some interesting cases. We make some discussions. So if you are facing some problem, you are just trying to ask some questions, just put the comment box, put it on comments box, and we will try to solve those also. And don't forget to share your location on the comment box. It actually helps other who are interested to join, and they can just see from where you are just trying to see our posts. So anyway, let's move forward. So today we are going to share 5 cases like before, and let's start with case number 1. So this will be a 25-year-old male patient who actually came to me this week with a history of perianal pedunculated painless swelling. Like, if you think this is the anal orifice of this patient, just from a little distance from the anal orifice, there was a large pedunculated mass, just like this shape, pedunculated mass attached to the perianal region. It was painless. It looks like the similar skin pattern. It quite looked like a scrotum actually. So I was a little bit confused looking at that, why the patient is just keeping this lesion. Clinician sent me this patient just to solve whether it's a vascular lesion or it's any other thing. So, okay, so let's start with the view. So I put the high frequency linear transducer over the lesion. And now I think most of you can easily say what is the diagnosis. So you can see there is a echogenic mass with striated pattern. This type of striations are very common in the subcutaneous tissue. So the echogenicity of the lesion is similar to the subcutaneous tissue of the body. So obviously the lesion is containing fat. So this is nothing but a lipoma. So it was just like this ball-like shape. So this is a big lipoma, and it was pedunculated attached to the left perianal region. Okay, so this is very easy case, but the clinician sent me because it might be a vascular lesion also. So is it a hemangioma or any vascular abnormality going on here? There is nothing. So this is the picture. You can see this is the lipoma of this patient, which was pedunculated. It would be better if I could take the picture, but it was a private part and patient didn't allow it. He was only 25-year-old, so feeling discomfort. And we don't want to disturb patient's privacy, obviously. So we put some Doppler and there was no definite detectable vascularity. Obviously, the lesion should have some vascularity, but it is very minimal and very insignificant. So we don't care about that. And obviously, this is a case of pedunculated lipoma. We tried to measure with the panoramic shot. We took a panoramic view, just swept the transducer over the lesion, and now you are getting this type of picture. So it's around 7 centimeters. So it's quite big, 7 centimeter long and 2.5 centimeter the anterior posterior diameter or width. So this is a case of pedunculated lipoma arising from the left perianal region. Okay, so walaikum assalam. So let's jump into the case number 2. So now all the cases will be a little bit bigger. So don't get disappointed. But these are some interesting cases, and most of the cases are from my recent practice. So I try to share cases with you so that you can actually feel the interest to practice more, and a more deep practice by you may also help other people to get a good diagnosis. Anyway, let's jump into the case number 2. So this is a 60-year-old male patient who came with a right iliac fossa pain. Okay, so when the patient comes with right iliac fossa pain, we just try to look for appendicular lesions or like that. But the patient came with more other complaints, like he complained about the difficulty of maturation. And when I saw the patient was on suprapubic catheterization. So suprapubic, not through the urethra. So that took our attention also. So let's see what we have got on ultrasound in this patient. So here we put the transducer at the right costal margin, and now you can see within the gallbladder lumen. Sometimes we miss these things. You see some sediments here, ecogenic sediments. These are actually ecogenic slurs. We took the pictures from different angles also. There was slurs inside, but I missed the video for this thing. So it's not a very important finding for this patient, so we will ignore it. But there was biliary slurs. So now when we try to measure other organs, we found that the kidney doesn't look quite normal. Ignore the liver, look at the right kidney. It's completely ecogenic. The ecogenicity of the parenchyma is similar to the sinus ecogenicity, and the kidney is very small in size, only 5.8 centimeter in length, and you can see some tiny cystic structures within the parenchyma. So this is definitely indicating the chronic nephropathy, or you may say chronic renal parenchyma disease, or is an quite like an end-stage kidney disease like appearance going on here. Okay, that's okay. So let's jump into the left kidney. So the left kidney looks almost similar. You can see it's only 6.7 centimeter long, and still there are some tiny cystic spaces, and the ecogenicity of the parenchyma is almost similar to the ecogenicity of the cortex, so or of the sinus. So we have lost the corticopendular differentiation. Obviously, we can't differentiate which one is the cortex, which one is the medulla. Even the sinus looks quite similar. So this is a case of bilateral chronic nephropathy with some cortical sears. But yeah, the patient came to me with the right iliac fossa pain. Patient came with suprapubic catheterization, which doesn't match with these findings. So let's jump into the lower abdomen. So here we have tried to measure the prostate, make sure this is the urinary bladder wall, which looks slightly thickened. It's around 5 millimeter, which is a common association with the catheterized patients. So yeah, the wall is slightly thickened. Now, here's the glimpse of the suprapubic catheter. Let me show here. You see, this is not the median lobe enlargement. This is the suprapubic catheter, which is within the urinary bladder in this view. And if you look at the skin and that region, this is the area of the catheter which is getting entered into the urinary bladder. This is the area of the catheter. So this is not the actual thing what I am going to show you for this case. So just some hints that this patient had a suprapubic catheterization and surrounding appearance of the cystitis due to this catheterized state, or it might be vice versa. Due to cystitis stage, patient couldn't void, so there might be some catheterization, whatever. The patient is quite non-cooperative, so it was very difficult to get the history. Anyway, let's jump into our main topic. Patient is on hospitalization. Okay, so we looked at the right iliac fossa with our curvilinear transducer, and now with the curvilinear transducer, you can see there are so many things here in the right iliac fossa. You see some ecogenic area here. These are not the bar loops. This is the ecogenic fat. So this thickening of the fat indicates that there is some inflammatory conditions going on over there. So we need to look a little bit further. So here is the thing which might be acute appendicitis. Here is the thing which might be acute ilitis. So there are so many things that can happen. So let's use the linear transducer to make the diagnosis. So now we are using the linear transducer, and I hope you can easily say what is the diagnosis here. You see, this is the terminal ileum. Let me freeze the image a little. Here are two findings, no, three findings. You see, this is the terminal ileum. This is not appendix. Make sure this is the terminal ileum, which will end into the cecum also. Now here you can see a little bit of collection here. And beside this collection, you see this structure. What is this? Is this a mass lesion or something like that? These are lymph nodes, you know. These are lymph nodes. You will see some tiny lymph nodes here, 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 and there. So there are some lymph nodes over there. So this is the terminal ileum, and this is some collection. So this one is the appendix. Let me show you this thing on a different view. So here's the picture. Now you can see this is the vermiform appendix, which is going here and entering into the cecum. This is the cecum region. Let me freeze the image a little. Here, just let me show you the total view of the appendix. Yeah, it will be okay. So here you can see this is the tip of the appendix. This is a blind-ended tubular structure. You can see some gut signature here, some hypoechoic area, and this appendix is going backwards, and here it is entering into the cecum. This is the cecum. This is the terminal ileum trying to enter into this part of the cecum. Okay, so this is the appendix, and you can see some thickening of the bowel at this thickening of the fat, surrounding fat layer is thickened. Okay, so we saw some collection at the at that area. So is this appendix got perforated? It will be a difficult question for ultrasound. We have seen some collection adjacent to it. So whenever you see some collection adjacent to an inflamed appendix, especially if you see a localized collection, you should be a little bit careful. So this patient will obviously go for a surgical procedure without any hesitation. Clinicians just send us the patient to make sure the appendix is quite normal. But we have said that the appendix is not normal, it is inflamed already. So here you can see these are the lymph nodes. Adjacent lymphadenopathy is very common. Mesenteric lymph nodes get inflamed also. So here you can see this is the appendix. You see this is the terminal ileum. This is the cecum where they are just trying to enter at that part. And this is the collection. The collection is also hazy, which took our attention also because it might be a feature of perforation. But when you are trying to say it is a perforated appendix, the diameter should be quite normal or normalized or trying to normalize, or there might be some breach in the continuity of the mucosa, which was very difficult to find in such cases. So here is the picture. You can see this is the appendix, this is the terminal ileum, this is the collection. So all are in a single picture. So here's another view. Now you can see this is the appendix. We tried to measure the appendix from outer to outer. The measurement was around 7 millimeter. So it might be, and definitely it is distended, but it might be was about 10 millimeter. Now it got ruptured. You can see that adjacent fluid. Now it got collapsed to 7 millimeter. That might be happening, or this fluid collection may be due to adjacent inflammatory process. So whenever you see a collection, just make sure you should report it, because this collection may create a significance related to perforation. Okay, so this is on the inflamed appendix, and this is the thickened fat. In CT, we commonly say it, okay, ignore it. So when I try to speak a lot, I make some mistakes, so whatever. So we call it fat stranding in CT, okay. So anyway, you can see some collection here. This is the collection, and these are the some lymph nodes which are just occupying this area. So we put some color Doppler, and now on color Doppler, you can see a good amount of vascularity within this area. Make sure you should also check the vascularity of the appendix, decreasing the pulse repetition frequency or PRF. Even you can use the power Doppler to ensure that the appendix wall has a vascularity, because if there is no vascularity, we also can think about the gangrenous change here. So here's the picture. We have reduced the PRF, but PRF is still more than the previous picture. And these are artifact, quite like artifact, but if you look carefully, there is some vascularity within the appendicular wall. Let me just move the image. uh, I don't think it will be. Yeah. These are the vascularity of the wall. These are the vascularity of the wall. So ignoring the artifacts, if you look a little bit, this is the wall vascularity. So if you look carefully, you may see some vascularity also. So best thing is that you should use the power Doppler to see the vascularity. And we have found some vascularity, so we are not focusing on the gangrenous changes like that. Okay, so here's the picture, the complete picture of the acute appendicitis, and the appendix is entering into the cecum. So this is a case of acute appendicitis and with bilateral chronic nephropathy having cortical cyst. We found biliary sludge and cystitis as associated findings. Okay, now let's look at the case number 3. So it will be a penile ultrasound case, and the patient was 52-year-old male patient who came with erectile dysfunction. You know, when we get the patients with erectile dysfunctions, we go for the penile Doppler study. Usually my clinician sent me with proper counseling. And if not, then I send the patient back to the clinician so that he can do whatever he needs. Okay, so anyway, here you can see the flaccid state of penis, where we can see the penis has on cross section 3 parts: 2 corpora cavernosa, having the cavernosal arteries inside, and this is the corpus spongiosum, having the urethra inside. And all these 3 layers are covered by the tunica albuginea. So here is the long section of the corpus cavernosa on the right and left. And these are the cavernosal arteries, which are usually 0.5 to 0.7 millimeter around diameter, which is not a very significant finding. Now, when we'll use the our drug, like injectable drug, then this diameter should get increased. Okay, so we try to take some measurements. Make sure, I'm sorry for not a good quality of the wave. Sometimes it's a little bit difficult to get a good flow from the cavernosal arteries. In such cases, you may also use the power Doppler to get a good view. Anyway, we found that the velocity was quite good in even in the flaccid state. It was 12 and 17 centimeter per second with a no diastolic forward flow. Okay, so up to this level, it is a normal finding. So penis is flaccid, both cavernosa and spongiosum look quite normal, and the artery looks quite good. There was no echogenic calcified or fibrous plaques within the tunica albuginea, so no feature of Perianal disease. Let's jump into the procedure. So we use the piperacillin injection. In my country, piperacillin is not widely available. We get 2 companies which sell the piperacillin. Both are from India, so these are imported drugs in my country and not always available. So we use the piperacillin hydrochloride 30 milligram. This ampoule contains 2 ml. So we use the insulin syringe, the 100 unit insulin syringe. So each 100 unit insulin syringe has the 1 ml capability. So we took the 1 ml injection per syringe, and then we inject into the corpus cavernosa. We inject at the root level of the corpus cavernosa of the penis. So just at the root level, we inject it into the corpus cavernosa. 1 ml, 1 ml, 2 ml in 2 part. Okay, so now after injection, when we try to see, you can see some echogenic bubbles inside this corpus cavernosa. These are the echogenic bubbles within the corpus cavernosa. Now we'll keep the patient wait for the 5 minutes, and then we will check the patient. So after 5 minutes, when we try to scan for the first time, now you can see the corpus spongiosum, corpus cavernosa on both sides look quite enlarged. So these are getting swollen. Because the blood is getting entered into these venous sinusoids. So the diameter we saw, it was 0.7 millimeter. Now it's 0.9 millimeter. So the arteries are getting dilated. And we check the flow. Now the flow is quite easy to get. You see, the right cavernous artery is showing 36 PSV and 9 in diastolic velocity, and peak systolic velocity on the left is 45 and 11. Now, if it crosses 30 or 25, depending on which method you follow. Anyway, if it crosses 25 or 30 centimeter per second of flow in peak systolic velocity, then you should exclude the atherosclerotic arteriogenic cause of erectile dysfunction. So already we have crossed the 30 centimeter per second range. So we can say that this patient is not having any arteriogenic cause of erectile dysfunction. So patient is quite good. But we couldn't exclude the venogenic cause in this patient. So we have to wait. You see, this is the in diastolic velocity, which is already 9 or 11. So after a certain amount of time, at least after 25 minutes, um, it should get reduced below 5 centimeter per second. Otherwise, we'll go for the venogenic cause. Let me show you. So here, after 5 minutes of scan, we have found that the penis is already erected, but it is not rigid. It's just quite like soft, but it is erected. So we have found increased in systolic and diastolic flows in the cavernous arteries. Now let's jump into the 15 minutes. After 15 minutes after injection, now you can see the diameter is still increased, and we check. Oh, the arteries are getting crazy right now. So you see the right cavernous artery is having peak systolic velocity of 86 centimeter per second. So this is the peak stage right now. And the left one is 88. So diastolic flow is still increased. We want to wait up to 25 minutes to see whether it is getting decreased or not. So we check the patient after 20 minutes and 25 minutes and even 30 minutes. So let me show you the 25 minutes scan. So here after 15 minutes, you see it's 86 centimeter per second. So your penis should get erected completely. But this patient had an erected penis, but it is still not rigid, which took our attention. The penis is getting supply from this cavernous artery. So when there is a process of erection going on, there will be a arterial flow going towards the venous, towards the sinusoid. So sinusoid will get filled with the blood, it will get erected. And there are some emissary vein which drain this sinusoidal blood out of the penis. So you need to stop these emissary veins to drain the blood, because we want to hold the blood within the penis so the penis will get erected. But if you cannot stop the emissary veins, then the penis won't get rigid. So this is the attention we are just going to solve. So after 25 minutes, now we still can see the penis is having a good amount of vascularity. The flow should get reduced because the penis should get already erected and the emissary veins should get closed. Helical arteries, which are the branches of this cavernous arteries, should get high resistant flow, and the cavernous artery should not be allowed to supply much. But still, we can see the cavernous arteries are supplying 31, 33 centimeter per second of flow, and the diastolic flow is still more than 5 centimeter per second. That means this patient is having a very good flow through the cavernous arteries, but you cannot stop the emissary veins. So the flow is, you're supplying a very good amount of flow and you're draining all the flow. So that's why you cannot hold the blood within the penile part and the penis is not getting rigid. So this is called the venogenic cause of erectile dysfunction. So make sure if the velocity gets above the peak systolic velocity gets above the 30 centimeter per second, you exclude the arteriogenic cause of erectile dysfunction. If you see the diastolic flow gets reduced less than 5 centimeter per second, or if you see the reverse flow, you exclude the venogenic cause of erectile dysfunction. So we found the first one, but the second one was not present. So the penis is still erected and not rigid. There was increase in the systolic flow, but there is still persistent increased diastolic flow. So this persistent diastolic flow in the cavernous arteries indicate the venogenic cause, indicate the venogenic cause of erectile dysfunction. Okay, so anyway, just let me check a little. Sorry for that. Okay. Oh, okay. Let's jump into the case number 4. Okay, I'm also connected to the Facebook Live here. The screen is going here. And here we have got very few participants. So if you find this video helpful, don't forget to share with your friends. It will be beneficial for us and will help us to make more videos for you. Make sure the Facebook deletes the live sessions after a month as new rule. So we'll just upload this video again in this Facebook page. And if you miss the previous parts, don't get disappointed. We'll upload the video, the record, in our YouTube channel tomorrow. So you can just get this video from our YouTube channel also. If you missed the previous videos, you can also get them in our YouTube channel, Imaging Study. Okay, so let's jump into the case number 4. So this patient was having, this is a 65-year-old male patient who came with the painful reddish whole body swelling. Like my assistant was just feeling hesitation about touching the patient. The whole body was reddish. There was a skin disruption going on. So it's quite, the patient gave me the history of like 1 month. Before 1 month, he was completely well. So I thought this might be a drug reaction or something like that. And the patient is having this type of cellulitis-like appearance. So anyway, this patient was sent to us because the legs were swollen. So the patient was sent to us for a lower limb vascular doppler study. So we checked the veins. Veins were quite normal. So we are showing you the arterial findings here. So when we check the right side, you see the vessels look quite not normal. So we have found some atherosclerotic change within these vessels, but and this is hemodynamically not significant. So we ignored them. So you see all the vessels, external iliac artery, common femoral, superficial femoral, deep femoral arteries on the right side, all are showing monophasic flow. If you see here, according to New York guideline, if you see the flow or wave on one side of the baseline, we call it monophasic. If we see the waves on both sides of the baseline, we call it multiphasic wave pattern. So here we can see the monophasic wave pattern. And if you look here, you can see the diastole is having a good amount of flow. You see this dome-shaped curvature here. So it indicates that it is giving you a vasodilatation flow, like we call it a monophasic hyperemic flow. So we are having a very good amount of hyperemia. So let's jump into the leg vessels. So from popliteal, you see the crazy amount of vascularity. So all the vessels are showing you a very good diastolic component and no reversal of flow. So we call it a monophasic hyperemic flow. So all the major arteries of the right lower limb are giving monophasic hyperemic flow, indicating vasodilatation, which might be due to the distal inflammation, or it might be due to increased demand. So let's look at the left one. So here on the left one, we see the similar pattern of flow. There is a good amount of flow in the diastole in all the vessels with a monophasic hyperemic nature. So you see on the popliteal, posterior tibial, anterior tibial, and arteria dorsalis pedis, like they're supplying very good. So you see some edema here also. We'll just come at that part later. So all the vessels are showing monophasic hyperemic flow. So it also indicates vasodilatation, possibly due to distal inflammation or due to increased demand. So now what is the conclusion here? Now you see this is the right mid thigh and mid leg, and this is the left mid thigh and mid leg. All are showing some edematous appearance. Definitely the patient is having reddish skin. So you see the edema, you see some features of vasodilatation and high amount of flow. So these features conclude it as a case of monophasic hyperemic flow in all the major bilateral lower limb arteries with leg edema it indicates this patient is having cellulitis. So these are the features of cellulitis in case of ultrasound. What else you can get in this patient? You may search for the inguinal lymphadenopathy, which is a very common association in such cases. If you, so this patient is having cellulitis. Okay, so if there was any obstruction, we can say that this hyperemic flow is due to increased demand. So there might be some obstructions. So due to the collateral pathway, similar flow pattern can be present in different arteries, but there should be some obstructed arteries also. But here there is no obstruction. Rather, you are seeing all the vessels showing similar type of pattern due to the inflammatory process. Okay, so to this last case, this will be the obviously the obstetric one. So I took a very bad case for the day, and it won't be very good case, I think. Okay, so case number 5. This is a 24-year-old female patient who came with an amenorrhea for 5 months. Let's see what we have got on ultrasound here. Now here on ultrasound, you can see we have tried to measure the baby. So it was 17, 16, 17. At this age, I preferably don't like to do the congenital anomaly scan or anatomy scan, whatever you say. In my center, we love to do the first trimester anomaly scan at 11 to 14 weeks, usually at the 12 to 13 weeks. And if I find the features are quite normal, we try to rescan the patient at 21 to 24 weeks. This is the preferable time for my practice, because at the 22 to 24 weeks, I find that the cardiac abnormalities are quite easy to differentiate, but it is usually missed at the 18 weeks. But this patient was sent to me at 17 weeks of gestation. So that was a little bit earlier. The patient was sent because there were some congenital anomalies in the regular scan found in regular pregnancy scan. So the clinician sent me to ensure whether this patient can survive or not. So let's see what we have got other findings here. So let's look at the fetal. Oh, what was that? So you can see some cystic area backside of the neck. So this is the cystic hygroma at this patient. Why it is cystic hygroma? Why it is not the encephalocele or something like that? You see some thin septation here. This tiny thin septation. Whenever you see a cystic space at the neck, just below the skin, outside the bony area, there is no bony defect here, and you see some internal septation, you go for the cystic hygroma. So this is a very common finding. But you see some other findings here also. You see, this is the ventricle. It doesn't look quite normal. So there should be some abnormalities going on here. Let me see from different angle. So we found that lateral ventricles are slightly dilated. That's another problem. Why the ventricles are dilated? So let's see the ventricles now. Okay, so let me freeze the image a little bit. These are the dilated lateral ventricles. Okay, so is the third ventricle dilated? Just let me go a little bit backward. Yeah, you see, this is the third ventricle. It is also dilated. So both third and lateral ventricles are dilated. So now we want to see the posterior fossa. So we need to ensure that the posterior fossa has no abnormality. If the cerebellum is quite normal, we'll go for the cerebral aqueductal stenosis. If the cerebellum is abnormal, then we'll think about the cerebral aqueduct stenosis or whatever. It is due to the cerebral defect, the cerebellar defect. Okay, so it's a little bit difficult to understand the cerebellum at this stage because it's 18 weeks, but still with our machine, we can actually detect if the position is quite good. Okay, let me see it from different angle. I have changed the cardiac setting. Cardiac setting is quite good to understand the abnormalities a little bit. So here we still can see the ventricles are slightly dilated, but I'm not pleased with the cerebellum. So the cerebellar region doesn't look quite normal. We can't see it quite well. So I'm not a little bit satisfied. So here we have tried a little bit. You can see this is the thalamus. Let me just show you. This is the cerebellar peduncle here, cerebral peduncle. And opposite to that, I'm not getting a good view of the cerebellum. So as it is an 17 week of gestation, we can go for a follow-up, or we can solve this case with TVS. But unfortunately, the baby is on breech presentation, so head abnormalities cannot be well understandable with TVS because it's far away from the range of TVS. So you can go for MRI. In my country, MRI is not well, uh, quite not popular in congenital abnormality exclusion but still, if your country has MRI facilities quite well, then you can obviously go for that. So anyway, we have found the lateral and third ventricles dilated. We are not satisfied with the fourth ventricle, so we are suspecting there should be some cerebellar defect in this patient, which we'll search on our follow-up scan, obviously. So we tried to do a sagittal section and took a color Doppler. So now on color Doppler, you can see this is the anterocerebral artery, which is giving the precallosal artery or callosal branches. So it indicates that the corpus callosum is still present. So there is no callosal defect, which is also a common association with the ventriculomegaly. So it's not present. But our focus is on this part. We are not satisfied with the view of the cerebellum till now. Here's the skin thickening here, which is also associated with the cavum, the cystic hygroma. Okay. Okay, this is the cystic hygroma. You see that we put the color Doppler and there was no vascularity here. So this cystic space is the cystic hygroma. Whenever you see the cystic hygroma, you should make some points. You get hydrops fetalis or whatever. In case of cystic hygroma, just make it very easy. If you see cystic hygroma, you first think of the Turner syndrome, which is a very common association. But you will see some renal defect in such patients. Okay, this is a very common association. But if you see cystic hygroma with a single umbilical cord artery, you'll go for the trisomy 18, that is Edwards syndrome. So in this patient, we want to solve whether the patient is having some renal defect or the patient is having some single umbilical artery. That will be very important finding. So let's jump into this patient again. So this is the cystic hygroma. So we are still looking at that part, and we couldn't conclude the diagnosis about the cerebellum. Okay, so here's some different view. Now you can see the lateral ventricles are dilated, and this is the cystic hygroma. Skin is slightly thickened, and that's okay for this view. Okay, so this is the next cystic hygroma. So measured it a little bit of 1.8 centimeter, which is not very important for us. It might be very large, it might be very small, but the fate is quite similar. Okay, so when I jumped into the chest, you can see this is the lung, and you can see pleural effusion. This patient had bilateral pleural effusion. But I'm also focusing on the heart here. This is the sagittal section of the heart, or long section, whatever you say. This is a bicaval view. This is the superior vena cava, and you see this is the inferior vena cava entering into the right side. So this is the right side of the heart. We need to ensure that both sides of the heart is quite normal, because in case of cystic hygroma cases, because we have found fluid in both cavities, like pleural cavities, and we found cystic hygroma. So this is a case of hydrops. There is no objection about that, but we need to exclude the cardiac anomaly in such cases. So let's see the chest right now. So here's the patient had bilateral pleural effusion. Both sides of the chest had the fluid collection. These patients commonly come with renal defect. Okay, so you need to search for the kidneys, but in such cases, sometimes kidney is very difficult to evaluate due to the appearance. Okay, so the fluid is not quite well. You see the amniotic fluid. If we get a very good amount of fluid, then it might be very easy. Okay, so we check the liver. It looks quite enlarged in comparison to the other structures. I missed the measurement here, but it looks quite enlarged for this age. So we suspected some hepatomegaly in such cases. So liver was quite big enough. And this, you see, this the liver is quite big. It is covering whole of the abdomen like thing. Okay, now let's look at the heart region. You see, it's not very satisfactory view to exclude the cardiac abnormality, but when we tried to search for the right heart, we saw that we saw the vena cava entering into the right heart. But when we tried to search for the left heart, we are not satisfied. We searched the left heart, but we couldn't get a very good view to say that the left heart is quite normal. So let's see that area from different angle. You see the fluid is quite low here. We need more amniotic fluid to get us such a good amount of view, but we are not getting a satisfactory view. Okay, from different angles, now you search for the heart and heart. So we always trying to see the right heart, but when we just sweeping the probe, we can't see anything in the left side. So we see the right heart very good, but we are moving the probe left and we can't find anything there. So here's the eggshell section. You see the heart is not actually giving you a very good four chamber view. In such cases, when you are not getting a good view, you definitely will go for a follow-up, but still you can use Doppler to see both inflow are normal or the outflow are normal. So we are trying to see again and again with echo setup. We are trying to see, uh, we are not satisfied. We are not having a good view of the left heart. You see, the right heart is pumping. This is the left side. You can't see it quite well. I know this is not a satisfactory view, but we try to search for the left heart and we know what we are looking for. So we put some Doppler. Unfortunately, we couldn't save the life of the Doppler. Anyway, so on the right, there was a good inflow, but on the left, there was apparently no flow there, or it was quite ill-defined flow. So we are suspecting the left-sided hypoplastic heart, but hypoplastic left heart in this case. So what to make the confirmatory diagnosis? Just to give a follow-up after 2 weeks, it will be enough. Okay, now let's come to the cord. So here we saw a cord around the neck. This is a single cord, so which might be not significant, but the cord is containing only two vessels. You see 1 and 2. So it should have 3 vessels, so 2 arteries and 1 vein, but here you can see 1 vein and 1 artery. So here we can see 2 vessel cord. So it will conclude the diagnosis. So here now you can see at the lower abdomen, there was only a single vessel at the lower abdomen, there is no vessel at this part. Just this might be a confusing view, so let's ignore it. So at the lower abdomen, this is the area of the bladder which already got evacuated. So we see only a single vessel, that is a single internal iliac artery in this patient. There should be 2 internal iliac arteries, one at this area and another one as this area, but there is only single internal iliac artery. So here, ignore this cave view. So here you can see from the aorta, it's getting here and only a single vessel is coming here. There is no vessel at this part. So it's not getting branched. So there is only a single umbilical cord artery. So whenever you are getting a cystic hygroma, I have told you, whenever you are getting cystic hygroma, you are getting features of hydrops fetalis. There is no RH immunization or whatever you say. So you think about Turner syndrome first. And if you see cystic hygroma with single umbilical cord artery, the first thing that should come in your mind is definitely the Edwards syndrome or trisomy 18. Okay, so this is the most common one. So in such cases, there should be some renal abnormalities, usually horseshoe kidney. Unfortunately, I couldn't detect the kidney here, or I couldn't exclude the congenital anomaly. We can see the kidney. Here is the glimpse of the kidney, but we couldn't exclude the horseshoe kidney in such patients. So if I can't say that that there is no horseshoe kidney, I will say, okay, so I won't say that the kidneys are normal in such cases. I will say that we have missed the horseshoe kidney in this patient. I won't say that the heart is normal. I will say that I have missed to diagnose cardiac abnormalities in this patient. Okay. So we'll go for a follow-up, obviously. Unfortunately, this patient didn't come back. So this was a case of about 17 to 18 weeks of single live intermittent pregnancy. There was multiple fetal congenital abnormalities. We found ventriculomegaly, possibly due to cerebral aqueductus stenosis, or without or with cerebellar defect. We are suspecting that there was cystic hygroma with skin thickening, bilateral proliferation. These two are enough to say a case of hydrops fetalis, and there was suspected hypoplastic left heart. There was hepatomegaly and single umbilical cord artery. So single umbilical artery and cystic hygroma, these two already say that this is a case of uh, trisomy 18 or Edwards syndrome. Will we write trisomy 18 or Edwards syndrome? Definitely not. But we'll say the clinician to exclude the trisomy 18, obviously, because this is a case of trisomy 18. So thank you for joining me in such long session. So in our imaging study, we have already uploaded many videos for you. So if you are free, if you are not feeling good, or if you want to see some cases, you can just go there and find our last cases. So there are so many cases, because 5 cases, 10 cases, 25 cases, so many videos have been uploaded. So you will get more than 600 or 700 video cases in our YouTube channel. So that might be enough for many different diagnoses. So we are trying to post some for you. So don't forget to share them with your friends, because we don't get views usually. Okay. So if we could post some dancing videos or song like videos or comedy videos, we will get much views. But for ultrasound like posts, we usually don't get views. So these are not economically beneficial for us, obviously, but it's fun to share our knowledge with you. So don't forget to share your knowledge with other persons who need them. Okay, so we have also a website, which is, we are very lazy to update this website. Anyway, so thank you for joining us. If you have any question, feel free to ask me in our Facebook Live. We have already posted this video in some groups, but yeah, I'm just getting connected to this one. Okay, about the next session, I haven't show you the next session schedule. So the next week, I will be a little bit busy with my school friends. Obviously, we have a program on 28 March, so we won't be able to make a session there. And after that, I think, just let me just check the calendar, so it will be helpful to say. So yeah, on the April 1st April, you will see the Friday is on April 4. So 4th April, unfortunately, I won't be in my country. I have a trip. Hopefully, I shouldn't say it, but yeah, on 4th April, I'll be in Nepal. So many people from Nepal are connected here. Yeah, I'll be in Nepal for a weekly trip on the very 1st April. So inshallah. So I won't be able to cast again. So hopefully our next session will be on April 11. Yeah, possibly on April 11. So there will be a 21 days of gap, I think. So 2 weeks, 3 weeks gap. So unfortunately, we are getting a 21 days of gap, but nothing to do. So anyway, so if I can take any station in between this time, so I will just inform you. And you can also check our YouTube videos. I'll try to post some videos there also. So anyway, thank you for joining me. If you find this video helpful, don't forget to share. Don't forget to follow us on our uh, Facebook, and obviously on our YouTube channel. Yeah, about the varicocele, today I had just tried to choose a case of grade 5 varicocele. There was an interesting case I found in this week. So I was trying to choose that case, but at the last moment, I changed my decision and uh, just chosen another one. So, okay, so for next time, I will just include the varicocele case, obviously. Okay, so anyway, thank you. So you'll get this video on in our YouTube channel tomorrow, and obviously it will be kept on our Facebook page. So from where you want to see, you can just see. So thank you for joining me. Hope to see you soon. See you on the next video. Allah Hafiz.